And then, hi everyone. Welcome to another episode of the Rafael Medina Subspecialty Virtual Morning Report. Today we have a very special session focusing on pulmonary and critical care medicine. And I'm very, very excited for today's session because we have CP Solver legend who is going to be presenting a case. I know he's just shaking his head now, but he is definitely a legend for CP Solver's members. So we have today as our case presenter, we have Curtin Patolia. So Curtin, you want to say hello to everyone and maybe you can also tell us maybe some highlights that you have last week.
Perfect. All right. Good morning, friends. Thank you for joining this session. I wanted to thank Yu Ting for the kind introduction. So yes, I am currently PGY3 resident at Cook County Hospital. Today, I have the pleasure of presenting a case to Dr. Stutz. Dr. Stutz is one of the PCCM attendings at our hospital and one of the attendings which I love the most. His teaching is impeccable. People love his personality and he is very good. He is like the modern doctor who has combination of dynamism as well as the wisdom. So we loved learning from him. So I invited him. So thanks for taking our invitation and coming here, Dr. Stars. I appreciate it. And yeah, last week, you think it has been a very busy week in residency currently because probably it's the first month with the new batch of interns. So it's like this delicate balance of supervising them adequately while also giving them their own freedom to order the things. So it has been kind of a learning curve, but it is good. It's going so far well. And I'm so excited that with this session, I will get chance to decompress myself from 1 week's hard work. So thanks for that.
Oh my God, I think I can relate to that. So being an intern, and I feel like having somebody like you as my senior will be something incredible because I feel like I would learn a lot from you. So yeah, so let me introduce our case discussant. So we have Dr. Matt Stutz. He is a med ped trained in pulmonary and critical care medicine at Cook County Rush University. He also attended to medical school at University of Chicago Pritzker School of Medicine. He did a residency at UCLA and fellowship at University of Chicago. So Dr. Stutz also has a master's degree in biomechanical informatics at the University of Chicago. So we are very, very excited to have you today. So welcome to the clinical problem solver session. And Matt, would you like to introduce, just say hello to everyone and also give us some highlight of last week?
Oh, wonderful. Well, it's an honor to be here. Thank you so much for the invitation. I really enjoy listening to the content you all produce on my drive. I've learned a ton from you and excited to hopefully give back a little. Let's see, fun things from last week. So I'm a dad. I have a 1-year-old and a 4-year-old. And my wife and I made a tough decision about whether we should buy a bouncy house or rent a bouncy house for my 4-year-old's birthday. We went with the buy option, and that was the right choice because now every weekend we like send out a mass text to the neighborhood kids. We're like, bouncy house is going up, and then it's just a good time to relax with the neighborhood friends and see the kids enjoy themselves. So that's been the highlight of my week the last couple weeks, I have to say, and hopefully for some weekends in the future too. Although Chicago weather is always unpredictable, but excited to be here. Thanks so much for having me.
Yeah, thank you so much. Being a dad must be very busy, so thank you so much for taking some of your time off to join us. And we are very excited to learn from you. So we have today two CP Solar member that will be helping us scribe and doing the teaching points. So we have Johan and Parisa, so thank you both for your help. And whenever you're ready, Johan, you can share the screen and show the whiteboard. Great. So Kirtan, whenever you're ready, the floor is yours.
Perfect. Thank you so much. You think we can get started with the first aliquot. So as always, I like to title the case because it's kind of fun. It gives a subtle hint and it also has a deeper meaning. So the title for today's case will be The Haunting Shadows. And maybe we can get started with the first aliquot. So we have a 59-year-old gentleman with medical history of end-stage renal disease and hypertension who was found unresponsive by family members at the home. He was confused and was found to have bilateral wrist lacerations with some empty bottles of diphenhydramine, nifedipine, and carvedilol laid beside him. He, as per the family members' collaborative history, he has been having just 1 hour of sleep at night for last 2 weeks, has not been able to do his scheduled peritoneal dialysis at home for last 1 week. No delusions or hallucinations reported as per the family members, and no suicidal ideation reported. Vitals were remarkable only for bradycardia on presentation and some basic labs. So he had hyponatremia to 125, hyperkalemia to 5.5, had some acidosis with bicarbonate of 20, BUN of 120, creatinine of 14, total protein 4.8, albumin 2.6, bilirubin, AST, ALT, and ALK phos were within the normal limits, and hemoglobin was 6.4. Ultimately, he was admitted to the hospital. He was in the ED, and he was found to have further complications on EKG. So given the fact that he was on diphenhydramine, we were worried that what if he has some anticholinergic kind of toxicity. So on EKG, he was found to have polymorphic ventricular tachycardia, unfortunately had cardiac arrest, but then ROSC was achieved after 2 rounds of CPR. He was intubated, and then eventually after 2 or 3 days, he was subsequently extubated successfully. And now we are into currently 4th or 5th day in the ICU, and he starts getting fever as high as 38.4 degrees, and he is still confused and disoriented. And that will be the end of first aliquot.
Wow. So, Kirtan, what a aliquot. As always, I love the title, first of all, Haunting Shadow. That's a great title. And we see this patient who is clearly sick. And actually, my question to Matt is that how would you approach the evaluation of fever of this patient in a post-cardiac arrest with this past medical history with end-stage renal disease and ongoing confusion?
Yeah, certainly a great case with a lot of data to it as well. And I think this isn't uncommon as patients are recovering from critical illness. And it sounds like he has made some progress and that he's been liberated from the ventilator, but still has a long way to go. And so I think my overall perspective is like, how can I try to guide this gentleman through the course of his critical illness and to some stability and to kind of further advance his care. And I think given that little aliquot, I think the fever is certainly concerning. And thinking about perhaps hospital-acquired infections or just infections in general, and a patient who had a cardiac arrest. So I'm guessing probably had some lines placed, was intubated, et cetera. So common things being common, I think starting by looking for infection. So it sounds like he's been liberated, but try to get the respiratory culture, get a chest x-ray, see if there was any aspiration event. It sounds like there was a suspected overdose and a depressed mental status. It still seems like he might be, a little altered. So I think looking for aspiration pneumonia would be smart. Evaluating whether he has any tubes, lines, and drains, and then not only getting cultures from those sites, like the blood and then probably the urine, but thinking about, do I need those tubes, lines, and drains? And if the answer is no, get him out of there. And maybe you needed to get him out of there yesterday. And so I think looking at blood and urine and an X-ray. Now the mental status and fever course concerning, and I think is difficult to pick apart in the ICU. I'm going to stick with kind of close out my infectious framework here. Fever and altered mental status, I think you have to think about some type of CNS infection. Although I have to say that right now I probably wouldn't put that on the highest of my list, given that he's kind of progressing through a hospital stay, and I think a hospital-acquired infection, would be less likely to be, a meningitis or encephalitis, but certainly something I'm keeping there. Wonderful. And then I think focusing on the fever, otherwise, I'd be interested to know what medications he has. Has he been on? I mean, broad spectrum antibiotics, beta-lactams, super commonly used in the ICU, of course. So, I wouldn't be rushing to discontinue antibiotics, but I would at least be interested in knowing, what he's been on and whether it's drug fever or not. And then, I'm kind of driving back into the mental status, but it also is important because cefepime neurotoxicity. There's a recent study, I believe, in either JAMA, New England Journal, came from the Vanderbilt group that looked at toxicity of Zosyn versus cefepime, and it turns out that the nephrotoxicity of Zosyn wasn't so much to be worrisome, but the neurotoxicity was cefepime. So, I think for double reasons, would think about which antibiotics he's been exposed to. Other common causes of fever, I guess maybe not common, but something to keep in mind on, or is there any sign of clots anywhere? He's been immobile. He may have not been on DVT prophylaxis with the anemia, so making sure he's appropriately prophylaxed, at least probably thinking about getting some lower extremity Dopplers. I don't think I've heard enough to get a scan of his his lungs yet, but something to keep in the back of your mind. I think the fever and altered mental status go together so well. I mean, they could also be true and unrelated, right? So delirium, particularly common in the ICU, particularly if his mental status is waxing and waning. I think that'd be a diagnosis of exclusion. I've kind of heard enough, like if the guy's been off sedation and not waking up and has had this traumatic history, I think you're going to want to rule out anatomic issues, or at least catastrophic anatomic issues like large strokes or hemorrhage or things like that, and make sure there's not anything in the background there. And then other metabolic causes of altered mental status. I mean, sodium's of 125 probably isn't helping him. The BUN of 120 is probably not helping him either, assuming those labs are still reflective of his current presentation. And then I think the other thing off the top of my head you'd want to be sure of is making sure that altered mental status isn't a representation of shock. I haven't heard some recent vital signs, but if he's still bradycardic, he's still hypotensive, and he's altered, that could just be one of your cues. So, but criteria, and maybe it's just hypoperfusion in the setting of that. I mean, I think those would be off the top of my head, common things being common. What I would look into. I guess I'd also probably put seizure on there as well. And if he'd been on the right antibiotics and he wasn't working up, I'd probably seriously think about ordering an EEG for him, especially if there's no rapid improvement. But I think I'd be right there. I guess I should finish that thought. I mean, subclinical status is something that you can sometimes miss and can be altered, and then people can be postictal, et cetera, et cetera. And then, if you are in a cefepime neurotoxicity land, that has a EEG pattern, et cetera. And then I probably should finish my thought on, I don't think I'd be rushing to LP the patient yet. But if he continues to fever and he doesn't respond to kind of broad spectrum antibiotics, I think I'd be moving to that in the near future.
Wow. I think you have given us a very thorough first clinical reasoning for the first aliquot with so much information. And I think I will keep on the back of my head the cefepime with neurotoxicity. So thank you for that detail. So Kirtan, you are feel free to continue with the second aliquot.
Perfect. Sure. Thank you. Thank you, Dr. Stutz, for highlighting all the points. I think Dr. Stutz was right on the money. He was anticipating everything. So this is what happened, that while he was in the ED, he eventually got the chest X-ray, and it showed there was concern for bibasilar opacities and possible aspiration pneumonitis versus pneumonia. So patient was started initially on narrow spectrum antibiotics, but then since he was intubated, this was an event of intoxication. We were not sure about the past history of the patient coherently. So that's why patient was switched to the broad spectrum. So he was on vanc and cefepime initially, but since the mental status was not improving, the concern was that maybe cefepime has to do something with it. So it was changed to zosyn, which is piperacillin tazobactam. And fortunately, after that, the mental status improved a little bit, but still he was quite altered. And I will give you that data in the examination point. So moving to the next aliquot regarding the past medical history. So the history is hypertension. He has ESRD on peritoneal dialysis. So usually people with peritoneal dialysis, they do the dialysis at their own home because they are well trained eventually. So as I discussed in the first aliquot, that he was actually not able to do the scheduled peritoneal dialysis for past 2 weeks. And family members had no idea as to why he was not able to do dialysis. Once he came to the hospital, we switched him to the hemodialysis, and he was getting regular hemodialysis, but still his mental status didn't improve and it was waxing and waning. His medications at home are losartan, nifedipine, and carvedilol for hypertension, and diphenhydramine for pruritus associated with end-stage renal disease. And in the first aliquot, I mentioned that he was found confused and there were bottles of nifedipine, carvedilol lying besides him. We were not sure that how many tablets were in those bottles, so we cannot gauge that how much overdose he had. Social history, he drinks alcohol and socially, and smoking occasionally, but nothing to write home about. And all of this history we are taking from the family members and chart review because patient is still untold, not able to converse. Vitals, so now that he has been 4 days into the course of illness, vitals are normal. So no bradycardia, heart rate was 78, blood pressure 122/78, saturating at 98% on room air, and respiratory rate was 16 breaths per minute. General examination, he was alert and oriented to self only. He was able to track with his eyes if you go into the room, try to engage with him, but he won't be able to give coherent response to any of your questions. Pulmonary examination, there were crackles in multifocal locations, reduced breath sounds at lung bases. Cardiologic examination with normal rate and rhythm, and all other review of systems and all other examination were unremarkable. So now moving to the basic labs. So in first aliquot, we discussed how he had hyponatremia and hyperkalemia. With the resuming dialysis, everything resolved. So the sodium levels were 136, potassium levels 4.8. Liver chemistry now seems to be evolving. So when he presented, the liver chemistry was unremarkable. But now we see that he has hyperbilirubinemia, so direct bilirubin of 3, direct bilirubin of 2. Transaminitis is present with AST of 200, ALT of 110, some degree of cholestasis with alkaline phosphatase of 437, GGT of 500, LDH of 373. The cell counts also seem to be evolving. So the CBC shows WBC of 3000, hemoglobin of 8, platelets of 60,000, coagulation panel PT of 18, INR 1.6, APTT 50. To further characterize this suspected aspiration pneumonia event and possible confusion stemming from it, we got the CT chest to better characterize the lung findings. And maybe I can share the image and let Dr. Stutz first read the scan, share how he goes through the scan, and then I can give the official radiology report as well.
That sounds great. While you pull that up, I guess the time frame I think in this case is a little challenging. I guess I just want to frame it up a little more.
Sure.
My discussion was thinking kind of we were 3 to 4 days into the course of critical illness, and I think that maybe that assumption was wrong. Was that about where we're at?
Yes, yes.
Okay. So, I think that I would like to say, if someone has BROSC and doesn't have a mental status, then fever is something you might want to address more actively, right? Because if someone is in a period of neurologic recovery, generally we think 42 to 78 hours, you're going to want to prevent their fevers, right? I mean, there's big multi or center randomized clinical trials on, post-ROS fever, and it being bad for neurologic outcomes. Now, you don't necessarily have to cool anymore, but you certainly want to prevent fever, I think, is the bottom line of that literature. I don't think that's where you want me to go on this talk, but I did want to just point out that immediate fever post ROSC without a mental status might require more intervention. And then I also think that, the toxidromes as well, I think are still on the differential, but as you're 3 to 4 days out, presumably several dialysis sessions in, I think those go down on your list as well. And then also just a plug for if you're suspecting a toxidrome or an ingestion, and that ingestant might be dialyzable, you're going to want to do single pass dialysis, right? That's doing all the work in 3 hours that CRRT or continuous dialysis machine would take 24 hours to do. So, and maybe I don't know off the top of my head if diphenhydramine is dialyzable. I don't think it is. And I don't think the other agents he was on are. So resolving, toxidrome could be on the differential, but just didn't want to miss those points there. To look at the CT scan, it looks like you have an infused image of the chest. And you kind of have like a mid chest cut. I'm not too impressed. I mean, there's some ground glass kind of throughout the chest bilaterally, and then it looks like there's some posterior consolidation on the right greater than left, and then looks like maybe there's some consolidation in the perivascular bundles and the retrocardiac space, but not too much to write home about, especially in someone who's undergone multiple rounds of CPR. You probably assume they have a little bit of pulmonary contusion, and that posterior stuff certainly could be atelectasis. So not the most benign CT chest. Like, could there be an infection like sitting in there? Totally. Am I rushing for my bronchoscope? Like, absolutely not. I think it's not that impressive. And maybe it's in a pattern that you could think there's some aspirating as well. I know there's not full cuts, but that's kind of what I can say from that. Oh, there's another cut you had another cut for me there. That was a good one. I mean, I just barely glanced at it, but I didn't see a big blown out RV. Yeah, I mean, when you're trying to think like, oh, does someone have signs of, a pulmonary embolism, and you're not scrolling through the pulmonary arteries looking for it, if you just want to look at the heart, whether the interventricular septum is flat, is the RV respecting the LV? Does the LV have a normal shape? And just in the one cut, I don't see anything horribly, concerning on that part.
Perfect. Thank you so much, Dr. Sir. So maybe I can give the official interpretation and move ahead. So as Dr. Sir predicted, there were bilateral GGOs, which are greatest in the parahiral and central lungs. Bilateral dependent pulmonary consolidation, which has imaging features of atelectasis. No pleural effusion or pneumothorax noted, and no evidence of pulmonary embolism. Given the fact that patient was still altered, despite the toxicologist saying us that by this time, all the things like carvedilol, nifedipine, diphenhydramine should have been out of the system. And we were not sure that why this patient is still altered despite getting the antibiotics for pneumonia, Vanc and Pip test. That's why we obtained the CT abdomen and pelvis. Also, because to further elucidate why the liver function was abnormal, so it showed there was some hepatomegaly, distended appearance of the central hepatic veins and intrahepatic inferior vena cava, cholelithiasis without evidence of cholecystitis, and no biliary ductal dilatation. Since the radiologists raised this concern that given the opacities, it could explain pulmonary edema, it could be explained by pulmonary edema as well. So we obtained the echo to see the functioning of the heart, and it showed the ejection fraction of 35 to 40% without any regional wall motion abnormalities. And that would be the end of secondary part.
So, Matt, so following a question about, we talk about the image with the CT. Would you mind to give us some differential diagnosis when we see on the CT scan ground glass opacity, and what does it mean to you as a pulmonary critical care medicine?
Yeah, great question. So unfortunately, it's not the most specific thing. When I am thinking about abnormal imaging that isn't a specific finding, white stuff in the lungs, for lack of a better term. I mean, I might get kicked out of pulmonologist society for saying that, but white stuff in the lung to me can be pus, so it can be infectious. It can be fluid, so it can be high pressure pulmonary edema, either from heart failure, renal failure, or liver failure, all with this gentleman has. It can be blood. So, if you see ground glass and that more diffusely throughout the lungs, like we saw in this case, that makes you more think of diffuse alveolar hemorrhage. I don't know. I don't think we have too much else to go on that. Don't need to go down that rabbit hole, I think, yet. So let's see. That's pus, blood, water, protein. So, protein, I think of just like a placeholder for kind of ARDS type issues. And then ARDS, of course, syndrome, which has an underlying cause. We don't need to dive into, but a lot of them are overlapping with the other parts of our differential. And then lastly, cells is like my placeholder for kind of more primary pulmonary things. So I think, eosinophilic pneumonia, or like acute or chronic. It could be organizing pneumonia. It could, I don't think any of these are particularly knockout. I think overall, diffuse ground glass in that setting, that could be from a variety of things: pulmonary contusion, a little infection, a little bit of high pressure pulmonary edema. I wish that my pulmonologist read of that scan could get us the diagnosis on this case, but I don't think it's really going to be all that helpful.
And also, I have another question. What do you think about the liver enzymes?
Yeah,
So,
absolutely. I think if we're reframing kind of in fever and altered mental status, and certainly someone who is febrile and just kind of isn't coming out of shock in that pattern of LFTs, you got to think about acalculous cholecystitis. I don't want to say I don't care that the CT doesn't show cholecystitis, but like it definitely doesn't make me feel any more secure about it. So I would be getting a right upper quadrant and a HIDA scan, one or the other, depending on what your local practice is, versus, depending on the suspicion, you could even think about just putting a drain in the gallbladder, kind of regardless of where you're at. But it does look to be like a more biliary pattern, especially. Well, then there is some AST ALT elevation in there, but I'd say probably more impressive for a biliary pattern. And the other thing you got to think about too is if he had an arrest 3 or 4 days ago, what's the trend, right? Because if his AST, ALT were kind of going up, plateauing, and then as they start to plateau and come down, your bili starts to kind of ratchet up there, that might be more concerning for shock liver. But in addition to that, you're going to want to send the medical workup. And my goodness, I should have mentioned Tylenol toxicity way earlier in this course, and just making sure we have a Tylenol level. Generally those get delivered to us in the ICU, which is really nice, but certainly would want to make sure a Tylenol level is okay. And then your viral hepatitis, and probably an anti-smooth muscle. And then I think probably have enough here to get the GI colleagues underway. Happy to be guided where you want me to go next. There's so much going on in this case, but I'm also interested in his coags and his CBC as well. But I can discuss that at a later time, or aliquot, however you would prefer.
yes. So Matt, actually, before we move forward for the next aliquot, there's a question that I am thinking about. You mentioned bronchoscopy, and you also mentioned that this is not very impressive, the CT. So when would you do or perform a bronchoscopy in a patient? What are the indications?
Sure. So I think in the ICU, oftentimes it's about not if a test is indicated, but when is the right time. So for instance, if this patient was still intubated and you had some suspicion, yeah, you can put a scope down, do a lavage, and it's not that big a deal. But in someone who is altered and you have concern is aspirating and does not have a protected airway, and I don't know really what diagnostic yield it would get me, that's what you're going to have a lot of a pause. So I think in someone who is high risk for a procedure, the juice has to be worth the squeeze. And if I was concerned, I think in this case for, hey, he has ESRD, he's got ground glass, like, are we really sure he doesn't have like an ANCA-associated vasculitis, right? Like, are we really sure about that? If I go in there and diagnose like DAH, like, am I going to be reaching for the pulse dose steroids? And in this case, honestly, I wouldn't be, because you just told me as an EF of 50 or 35%, he probably got a ton of fluids in his last 4 days in the MICU. And even if I serial lavaged him and he had DAH, I would be more likely to think that it was, bland hemorrhage from high pressure pulmonary edema than like a pure capillaritis. Now, we might want to open up the rheumatologic basket and see, but yeah, I think in the ICU, it's all about the timing, maybe not the indication. If this persisted, and it wasn't getting better, and perhaps his respiratory failure got worse, then maybe that moves bronchoscopy higher up on the list of things to do. But I think right now, for those kind of quick reasons, I think kind of the risks outweigh the benefits. And then the other thing to know about bronchoscopy, it's almost never a therapeutic intervention. I mean, a massive hemoptysis, sure, it can be helpful. But in this case, it would be diagnostic, I think, if anything. And so I think the bar has to be pretty high.
Thank you so much for clarifying. Now, Curtin, you can continue with your aliqua.
Perfect. Thank you so much, Dr. Stutz, for laying down all the framework. And at this moment, I also wanted to summarize for everybody, because same thing happened to us. We are also confused that what are we trying to solve in this case? So many things going on. And this is what happens in ICU sometimes. People come with some reason, they develop some complications. You are not sure what's going on. So for this gentleman, as I said, the primary reason for admission was the suspected suicide attempt. So regarding that, let me clarify certain things. Down the line, when he was in the ICU, eventually he got extubated. So at that point in time, the psychiatry colleagues came, they interviewed the family members, and they tried to get the information that what's the background for this gentleman. So the background of this gentleman is actually pretty unremarkable. Like, he lives with family. He doesn't report any recent conflicts with any of the family members or at the workplace. And they were also not sure that why he suddenly started behaving a little bit abnormally for past 1 or 2 weeks, because he started missing his own PD sessions. Usually he was very good about his PD sessions. He will go at night and make sure that PD catheter is in place, everything is drained, but he was not able to do so for last 2 weeks. And he was also not getting enough sleep, and no other toxic exposures reported, like at the workplace, like any gases, any surreptitious drug use, any IV drug use, nothing. And we did the tox screen multiple times. We even did the expanded tox screen to make sure we are not missing any other entities, and all the tox screens were unremarkable. So initially everything was concerning for beta blocker along with diphenhydramine toxidrome, but eventually everything stabilized from that perspective. Vitals are still stable, no concern for diphenhydramine or carvedilol. So I wanted to lay down that part. Apart from the psychiatric history, now in our ICU, our focus was on figuring out that why he has this fever, which is not responsive to antibiotics which we are giving, and what to do with this CBC and liver function test. So let me give you the evolution of those parameters so that we can move ahead. All right, so he is still on Vanc and Piptazo. He was not responding, so team thought that although we are not able to yield any organism from blood or urine cultures, let's expand it further. So they went from Vanc to marrow pene, and still fevers were not responding. Liver chemistry. So bilirubin keeps on rising. It is now 5, direct being 3. ALK-phos GGT also keeps on rising. ALK-phos is 500, GGT is 750. And AST ALT actually normalized. Ultrasound of the liver was pursued given these abnormal findings, and it showed cholecystitis. Now on the CT scan which we obtained, there was no evidence of cholecystitis, just gallstones. But the ultrasound of the liver showed cholecystitis. CBC shows further worsening of pancytopenia. So WBC is 2.5K, hemoglobin is 7, platelets 75,000. Coags, which Dr. Stutz was interested in seeing. So it actually shows almost same as the prior aliquot, PT of 20, INR of 2, APTT 55. Fibrinogen levels were elevated. They were like 550. CRP was obtained. CRP was elevated at 5, which is considered as slightly elevated in our lab. Ferritin was 3000. And repeat CT scan was obtained along with the echo. So the echo, first let me tell right away. So echo actually showed improvement in ejection fraction. It showed 50 to 55% EF. And maybe the repeat CT scan I can show. And again, the same thing I will ask Dr. Stutz to interpret for us. And then I can share the official interpretation.
Yeah, really interesting. The echo got better. It's not uncommon, in the ICU, someone has a stress, stress cardiomyopathy or something like that, or some, some type of insult, and then it gets better. Yeah, so on this scan, I think that those same areas that had ground glass are starting to get perhaps mixed with consolidation. The difference between ground glass and consolidation is consolidation, you cannot make out the underlying lung architecture, whereas ground glass, you see white stuff, but you can make out the underlying lung architecture. So, you can have, so you can have both in the same scan, and it looks like, some of that is consolidation and some of that is ground glass. Kind of the right anterior lung, there almost gives you a flavor that there might be some nodules. And then I can't help but see some of the chat things come up, and someone brings the question of crazy paving. And so what crazy paving is ground glass on top of intralobular septal thickening. And so I guess I can't point, but whoever's sharing the image might be able to outline the pulmonary intralobular septae, which are like these kind of octagonal things that that are more prominent in the periphery. I don't really see them here with a whole lot of confidence. And so I wouldn't call crazy paving on this particular scan, but sometimes crazy paving is a nice thing to call. There is a differential for it. PAP gets put on there, but it's really much more broader. I mean, like things like ARDS or DAH or atypical infections can all cause that. But that's my thought of that slice of the CT scan. Certainly more concerning than the first. Certainly could be infected or pulmonary edema. Again, kind of just diffuse white stuff in the lungs, unfortunately, just isn't the most helpful. Whereas things that are like, cavitary or in one particular lung than the other tend to be a little bit more specific. But yeah, again, here there's really just, I would say, diffuse ground glass with scattered consolidation more in the posterior segments. Certainly be interested in non-invasive infectious workup. I mean, I'm sure you're going to address that gallbladder issue. And then I think there's a lot to discuss in the pancytopenia and the rest of the labs you gave me as well. I don't think the lung's an innocent bystander here, but there are reasons of critical illness the lungs could look like this. And I don't think I'd really let this distract me from the overall kind of trajectory of the case. And I wanted to bring one other thing up before we move on, is when so much is happening in the ICU, and it's often nice to take a step back and just say, okay, well, like, what's keeping this patient here? Like, what do I need to get better to move the patient forward, get him outside of the ICU, get him outside of all the bad things that happen in the ICU? And really, it sounds like, besides the horrible labs, which I don't think a hospitalist would like, but it would be his mental status. His mental status and pancytopenia, I mean, I think need to be addressed, and I think you need to target there. Because I think that's what's chaining him to the ICU, at least in my mind right now. That and a whole lot of turn stones. But I think that's really where I would put a lot of my thought and energy.
Yeah, that was an actually great teaching Pearl and asking the question of why we're keeping this patient here, and that I think we see it every single day. Is it something that what is it? Is it like autoimmune status, or is the patient cannot breathe by its own, or is there anything that we can do in critical care that we cannot do on the floor? So that's a good reminder. So Curtin, tell us more.
Perfect. Sure. Thank you. Excellent. So we were moving the case ahead. We were thinking that why this person has obesity is why the fevers are not responding. So first thing was we were thinking that do we need to think apart from the classic organism? So we sent the 1,3-beta-D-glucan, we sent the serum galactomannan, we sent the urine histo, serum blasto, making sure we are not missing any fungal stuff. And eventually down the line, all of those tests came back negative. There was no evidence of any fungal infection. Second thing which Dr. Stutz and people in the chat were alluding that what's going on with the altered mental status. Because at this point in time, we obtained all the metabolic parameters to rule out any causes of encephalopathy. So no hyponatremia, BUN was improving, thyroid function were within the normal limits, cortisol levels were normal, UA had no other evidence of infection. Some autoimmune serologies were obtained, ANA, ANCA, negative, complements levels were within the normal limits as well. Rheumatoid factor, CCP, CK levels, just to make sure that the lung findings are not any subtle ILD. So none of them, all of them were negative. So connective tissue disease serologies were unremarkable. Meanwhile, the labs continue to worsen. So now the liver chemistry is showing even more profound cholestasis. Bilirubin was 7, direct bilirubin being fine, ALP 700, GGT 800, AST, ALT again starting to creep up a little bit, 300. Pancytopenia is more profound now, WBC 1000, hemoglobin 7, platelets 50,000. Ferritin was above the 7,500, which is the detection limit in our lab. And as people in the chat were rightly thinking that could this be HLH? So to further elucidate that, we obtained the triglycerides level, which were also elevated at 600, coags INR 1.7, APTT 100, and fibrinogen, which was actually higher during the past few days, now starts to become lower. So for the first time, fibrinogen is now below 150. Repeat echo, again same 55 to 60%. So what Dr. Stutz were saying, we also thought the same, that maybe this was stress cardiomyopathy, nothing to be excited about there. Other infectious markers still negative to date, which means procalcitonin was slightly elevated, but not too elevated. 1,3-beta-D-glucan, galactomannan, all unremarkable. Blood cultures, urine cultures still didn't grow anything. Regarding the ultrasound, which I shared earlier, that patient had some cholecystitis. So nuclear medicine scan was obtained because findings were equivocal, and we were wondering that could this person have acalculous cholecystitis, which is somehow contributing to him being sick. So we got the nuclear medicine HIDA scan, unremarkable. Surgery colleagues said that we don't think cholecystitis has to do anything with the altered mental status or with the worsening cytopenias. So this is actually all the information I have at this point. So I will just try to summarize to make sure that Dr. Stutz can have a final overview of what we were trying to do. So at this point in time, we still don't know why the lung infiltrates are worsening despite being on this VANC and meropenem and negative fungal markers. Secondly, we don't have a good explanation for why this person has HLH-like labs. We have not confirmed HLH yet, but we don't know why this person has HLH-like labs. Thirdly, we don't know why this person has DIC-like labs going on despite all the cultures being negative for any standard bacteria. And this is why I titled it as like haunting shadows. Like we don't know why these shadows in the lungs. So yeah, that's the end of this eloquence.
Yeah, I think I hate to keep harping on the gallbladder, but I think this is where you do have to say, okay, well, I get that you don't think it's the gallbladder, but it's suspicious and this patient's not getting better, like can we just drain it, and just work with them on the coags and whatnot. Now, I don't think that's necessarily all that's going on, but I would like to take that off the table, because if you have an undrained source of infection, no matter what else you're going to do isn't going to get the patient better. I think turning the attention to the pancytopenia is pretty prudent at this point. We've kind of been dancing around it. But can I ask, did the patient have splenomegaly? I missed it.
Oh, yes. No. So
Yeah.
the repeat pan CT was obtained. It
Yeah.
didn't show a splenomegaly.
It didn't. So I think you need to get HLH. I mean, I think you need 5 of 9. And so I think he has the fever. He has the byline cytopenia, has hypertriglyceridemia. He has the ferritin. So you'll probably send your other confirmatory labs like the NK cell activity and the CD25. But I think you also just need to get the bone marrow at this point. So I would be consulting hematology, probably or hopefully earlier in the case, but looking at that. And then you already mentioned a lot of the causes of HLH. So you told me that his rheumatologic panel was negative. You really looked for infection, malignancy workup. You have a pan scan. It doesn't sound like there's a smoking gun. So whether he has an acute leukemia leading to this, and then infection. And so, I think other infectious, etiologies that can cause, pancytopenia, as well as, TB can do that. We see a lot of TB. I didn't hear any risk factors. But I think, in TB, and he does have the consolidations, but nothing of the consolidations, I guess, was really typical of TB. So I think that would be a little far out, although that could be something you would pick up on the bone marrow. So I think looking for infectious things on the bone marrow and malignant things on the bone marrow that would perhaps give you HLH could be something. And then the other thing that jumps to mind is like TTP, this guy has fever, anemia, thrombocytopenia, renal dysfunction, and neurotoxicity. I know he's had CKD or ESRD for a while now, but are we really sure that he doesn't have TTP? And so getting an Adams TS13, would probably be a good idea. I think HUS would be less likely, but kind of on that spectrum as well. And then, asking the experts about that, and getting the nephrologist and the hematologist, oncologist all involved. But I think going down TTP, getting to the bottom of what's going on in the bone marrow with the bone marrow biopsy and culture, and if the patient gets intubated, then I think you could go after the bronchoscopy with BAL. But if he's still kind of altered and in and out, and you're sedating him, you could end up backsliding. If you do a bronchoscopy to intubate him, then you're sedating him, and then you're going to struggle. Yeah, so I think that would be my order of attack. I would kind of approach IR about putting a percutaneous drain in. I would talk with hematology and very much advocate for a bone marrow biopsy, looking for malignancy in culture, with the atypical organism sent as well. And then think about TTP, and if we need to start thinking about plex and plasmapheresis. And then an LP, I don't think I heard any LP studies, but I think it certainly needs to be done, and probably needed to be done earlier. And then sending that for all the atypical organisms as well. And then I guess I don't know what his ANC is. I know you sent the non-invasive fungal workup, et cetera, but prolonged neutropenia, which I doubt this guy had, because it sounds like it was kind of developed in the hospital, can be a risk factor for fungal things, like aspergillus, et cetera. But that would be interested. I'd also be interested to know if he has a quant as well. By a quant, I mean a quant gold, like a IGRA.
Perfect. So yes, Dr. Says, thank you for laying down the final pieces of details, and maybe I can now give the final results that what happened. So eventually we are also having the same tension which you are having, that do we need to do the bronchoscopy of this person to figure out what other organisms could be growing in the lungs, because all the non-invasive markers have been unremarkable. Even the sputum smears for AFB sputum cultures were not yielding anything. There was low concern for PJP pneumonia given the lung findings and given the fact that there are no other risk factors. So we were thinking that the ideal way to move ahead is getting the bone marrow. So we got the bone marrow, and the bone marrow actually showed that there was diffuse granulomatous inflammation in the bone marrow. There were caseating granulomas in the bone marrow, and some acid-fast bacilli were also identified. Severe hemophagocytosis was also present. And that's the end of final report. And this is all the data I have. So Dr. Sars, if you maybe want a final stab at this, just interpret it. And then I will tell you that what happened after this discovery and how we ended the case.
I mean, granulomatous inflammation with AFBs, I mean, is TB, 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 you'd start them on that. I've started right for a lot less. Let's put it that way. So, yeah, I mean, why would he have TB? I mean, I don't know. He's ESRD. We didn't hear any risk factors. It sounds like he was ESRD and then had a period where he wasn't doing his PD and then just suffered critical illness. So that alone, could be a wonderful setup to have reactivation of your TB, kind of an acquired immune deficiency. Other granulomatous inflammation, I think about sarcoid, but gosh, I mean, that would be pretty far out for sarcoid to also have AFB in there and then have, this presentation, although, neurosarcoid can have some really wild presentations, but, I'd be much less excited about that. The other thing I would say is you can find out really quickly if it's TB or not by just running a PCR. I understand that that may not be lost on this audience who practice all over the world, but I think in the United States, we're less familiar with tuberculosis diagnostic testing in general. And you can run the PCR, although it's not FDA approved for, things other than sputum, but you can really put anything you'd like in there. And I think this would be one I would be calling the lab director up right away and saying, hey, I need you to PCR this for me. And I don't know off the top of my head what the sensitivity and specificity is on bone marrow, but in general, the specificity is really, really high. And then the sensitivities, depending on the fluid, is anywhere from 60 to like high 90s. So I'd be getting with the lab director, and while I was waiting, I would be starting him on the on treatment for tuberculosis. And then I guess I didn't hear anything about malignancy in there as well. And I think the broad spectrum antibiotics you have them on is probably fine. But yeah, I didn't hear anything else really excited on the pathology report. And TB can be really difficult. It would be really interesting to know if that were TB, in the lungs, that wouldn't be a classic, presentation for pulmonary tuberculosis. You would think of, apical posterior soup seg cavitary lesions or, some tree and bud nodularity. But, could all that be TB? Yeah. It would be interesting to know.
Perfect. Thank you so much, Dr. Stutz. So
I guess I should mention NTMs. Yeah, I don't know what NTMs can cause bone marrow infection off the top of my head. And of course, you'd be getting your ID colleagues involved as well. That's not something I can think of. And then you get your AFB blood cultures, but you have like a great AFB culture off your bone marrow. So you'd probably get the AFB blood cultures, but you'd probably be set up off the culture on the bone marrow. And again, I think your PCR is gonna get it figured out for you, hopefully pretty quickly.
Perfect. Thank you so much, Dr. Stutz. So let me give you the conclusion. Yeah, you think you wanna go?
No, you can go ahead. Tell us what is the final diagnosis.
Okay, perfect. So we were also confused as to how to interpret these AFB smears. Now, let me tell you the journey. Unfortunately, what happened was that this patient was becoming sick so fast, and all these bone marrow biopsy, the results came actually after he passed away, because while he was in the hospital, he was getting more and more cytopenic, and he was going into multi-organ failure. He was not responding to vasopressors. His oxygen requirements were increasing. He was re-intubated. He was still altered. And before all these tests came back, unfortunately, he had passed away. So once these tests came back, we started to look everything retrospectively. That now that we know that this person has AFBs in the bone marrow, is it possible that he has AFB in the lungs as well? And the question is, it is definitely possible. And we know that although AFB, sputum, smears, and PCR are very good, but culture is the gold standard. And by culture, I mean you have to wait for 4 to 6 weeks. We have seen so many cases which yield cultures after 3 weeks, after 4 weeks, because in some settings, just PCR doesn't yield you something. If it is very low in quantity, it is definitely possible. So all the cultures were negative by the time he passed away. So we are not sure if he had TB in the lungs. Now, could lavage would have helped? That is also something which I'm not sure, as Dr. Stutz was saying, that maybe it could help, but we don't have a slam dunk that it will yield you this NTMs or TB in the lungs. So, but eventually we concluded that since he has no other classic risk factors, but he is coming from the endemic country. So this gentleman was from China, and last time he visited China was probably like 2 years ago. And we know that TB is one of those organisms which doesn't need immunocompromised status to disseminate. It can disseminate in various forms in various individuals. So although the lung findings were not classic, but given the fact that we firmly ruled out the pulmonary edema, we firmly ruled out any typical bacterial causes by this extended antibiotics which we give, and still it were worsening. And the final read on CT, which I showed, was nodular consolidations and GGOs more worse on the right side, which in some settings could be seen in disseminated TB, although definitely not classic, I agree. And the final piece of puzzle was that what happened to him that he went into this suicide attempt and everything. So that is why the deeper meaning of the haunting shadows, that we are chasing the shadow of TB in the lungs. But what about the imprint of TB on the brain? Because often whenever people commit suicide attempt, we just assume that, you know what, whatever thing is happening to this person now has to be linked to the suicide attempt. So we will choke it down, everything, to why this patient took the drugs, maybe this is from the drugs or not. And unfortunately, that is what happened during the hospitalization, that at some point in time, most of the team members were fixated on this thing. They were like, okay, this patient is actively going down the spiral, but maybe that's all because of the suicide attempt and complications from it. But we have to take a step back and ask ourselves that how many people you see in the world who are fine all their life, and then just in 2 weeks they start off getting a suicide attempt without having any family conflicts or anything. So that is what made us wonder that what if this was a secondary cause of psychosis, secondary cause of suicidal attempt. And we were also suspecting that maybe this person had TB meningitis, because if you think about it, it makes a good story, right? He has fevers, he has multi-organ failure, he has these suicidal attempts as well. We wanted to get the LP, but since he was so unstable, like he was on multiple vasopressors, no neurologist and not even interventional radiology team was comfortable with doing the LP. And same with the MRI as well, because now since this patient was altered through and through, we are not able to do a clear MRI clearance. Like if he has any metallic objects in the body or not, we are not able to say for sure. And the neurologists were thinking that we are not sure that how LP findings might help us. And again, as I'm telling you, this AFB in the bone marrow came after he passed away. If it had come before he passed away, maybe there would have been more impetus to obtain the MRI of the brain, but everything happened after. So you could imagine that it is easy now to say in retrospect that, yeah, he had TB meningitis, he had TB in the lungs. But when you are in midst of it, patient is going down the hill, there is really not much that we could have predicted. We did predict that it was HLH, and we did thought that maybe it's mycobacterial infection, but going to the conclusion that mycobacterium was in the lungs as well was a too far jump, and we couldn't have, I guess, done that at that point in time. So that is how the case ended. But still, it looks like that if we had to summarize everything, we could say that maybe the person had disseminated TB, which caused HLH, given the fact that bone marrow did show it. And yeah, sadly, that's how it ended. But hopefully in the future, we could try to catch this more effectively earlier in time so that we could intervene on it. So any final comments, you think, or Dr. Stutz?
Yeah, wow. So First of all, I'm so sorry for the outcome. I'm sure that your team did everything possible to get the diagnosis, but unfortunately, this patient passed away. And thank you for so many teaching. And of course, this is a great case as always. So be respectful for everybody's time. I would like to ask you, Curtin, if you have some final reflection, and with Matt, if you can think about maybe 3 teaching points for us before we end the session. Okay, Curtin.
Sure. Yeah. Thank you so much, Yuting, for amazing facilitation and asking all the right questions. I also wanted to thank Parisa for helping with the teaching points and Johan with the scribing. And yes, for my side, as I said, it was a good learning opportunity. We had differences in our mind that, okay, maybe this is TB, that's why the lungs are not clearing up. Maybe it caused the HLH, but I didn't have that much, how to say, acumen, diagnostic acumen or expertise at that moment in time that what could I have done more to bring him back. So, Dr. Stutz, what about your thoughts? Do you think you could have done something differently?
Oh my gosh, I mean, such a complicated case. I think it's hard to with so many curveballs, I think it's hard to say, you do anything differently. I mean, of course, hindsight being 2020, perhaps, you'd do the bone marrow earlier, right? To give the time to make the diagnosis and then and perhaps, start the patient on treatment. But I think that's just hindsight and maybe what you'd wish more so than what I would have done differently without the retrospectoscope. But I think for the teaching points, number one, I would just say think about what's keeping your patient in the ICU, what's keeping them in the hospital, and then really try to focus on figuring out what the underlying cause of that is, and then what can I do to make it better to move that patient's care plan along? Because if you're not making forward progress, you're going to start sliding backwards really quickly. Two is TB can really do anything. I think Curtin and I practice in an environment where TB humbles me pretty much every day. And if it's not every day, it's because maybe I was taking the day off or something. And then, third, um, hmm, those were my two good ones. I think the third thing I would keep in mind would just be to not be shy to continually reassess. I mean, there are so many different things on this differential, so many to get lost in. But I think taking a step back and reassessing and it would be important, particularly when patients are in the hospital for long periods of time and can get lost in what's here and now and then. But reassessing what are the issues now, and what can we do to move forward?
Thank you so much, Matt, for those amazing teaching points. And again, Curtin, thank you so much. We always know that every time you bring a case, it's always like twists and turns. So this is not different than others. So thank you so much for bringing the case. And thank you, Matt, for an amazing case discussion. And thank you everyone for joining today and participating on the chat. And I will see you on the next subspecialty VMR. Bye-bye.